Hello everyone, this is Alraies from SCAI 2023 in Phoenix. I'm really privileged to be with Dr. Greenbaum, who gave a phenomenal lecture about the history as well as the future of structural heart intervention. Dr. Greenbaum, thanks for being with us.
Oh, it's my pleasure.
Yeah. So you're an innovator, you are a structural interventionist, but definitely your innovation with your team has definitely pushed the envelope forward. So tell us a little bit the history and where are we now?
Sure. So we certainly have, and it really started 10 years ago, almost to the day, which is kind of fun for us to actually present some of this work at this meeting as opposed to others. But about 10 years ago, in conjunction with a true genius and a friend of mine for a long time, Robert Letterman, we performed the first, what is now referred to as transcaval TAVI. We used caval aortic access to gain access for valve delivery by starting in the IVC, crossing the retroperitoneal space, and entering the aorta below the renals, and then delivering the valve. And we used what we refer to now as transcatheter electrosurgery. We electrified the tip of a wire to aid in traversal of the two walls, and then of course we cross the walls with the catheter. And so that sort of set the stage for what we now refer to as transcatheter electrosurgery, because what we then said was, well, if we're okay crossing some walls, meaning passing some boundaries, and if we're willing to use electrosurgery principles inside the body, what else could we do? And so that set the stage for really all these other procedures.
Right.
Yeah.
So this is started 10 years ago, but definitely there is a subsequent innovation because the population we treat is more difficult, they have different anatomy.
Correct.
And also the surgical cases. So tell us more about that.
Right. So after that, while we were continuing to investigate that, the field of structural started to move into mitral interventions and transcatheter mitral valve replacement. And of course, very shortly after we started doing that, we realized that this permanent displacement of the anterior leaflet was a huge problem. In fact, there were some catastrophic outcomes. And when we started to figure out, okay, there's simply not enough room for that leaflet to come over and be permanently pushed in the open position, preventing the procedure, we thought about it and we said, well, the surgeons cut it out, right? So could we use these principles to cut that leaflet, or at least modify it to get it out of the way? And that led to this procedure that we know today as LAMPOON, right? So in actually early 2016, Vasilis Babilaros, my good friend and now actually my partner at Emory, was the one who said, hey, let's use these techniques to see if we can modify that leaflet. And so again, working with Dr. Letterman and now Dr. Khan at the NIH, we said, hey, can you figure out how to modify this leaflet? And actually within 5 weeks of that request, we were actually able to perform LAMPOON or anterior leaflet modification to allow successful TMVR. So the lecture yesterday was about the promise of transcatheter electrosurgery, and indeed that's one of the promises, that because we use off-the-shelf products that are available today, guiding catheters that we know how to use, coronary wires that we know how to use, and we can navigate blood vessels, right? That's what we do, that's what we did, that's what we trained for, that's what we did in all these years of PCI, that we can modify those tools to do other things. So that led, of course, to BASILICA, right? Modification of the aortic leaflets. And then most recently we said, well, could we cut more than leaflets? Could we cut muscle, right? And so for those patients who need more room that even LAMPOON can't supply, we said, hey, could we mimic surgical treatments for hypertrophic cardiomyopathy, namely myotomy? And the answer is yes. We, in conjunction with Chris Bruce, right, a current fellow at the NIH, who was investigating myocardial navigation, moving wires in the muscle where you have actually now freedom to do what you want, he was able to work out the steps to traverse the hypertrophied segment of muscle in the LVOT, re-enter the LV, and then using, again, electrosurgery now, make a linear slice mimicking surgical myotomy to also further prevent LVOT obstruction and treat HOCM. So our latest project actually involves lacerating muscle.
Do you have a call, something called for this procedure?
This procedure is called SESAME. Hokum Sesame.
Hokum Sesame.
is the current acronym for that procedure.
That's nice. Yeah. So this is for a patient with undergoing valve-in-valve mitral to modify.
So either valve-in-valve, valve-in-ring, or potentially just in native MAC or native TMVR to modify the septum. For instance, dedicated transcatheter mitral valves have no open cells.
Yeah.
So the only way to make room for them is thin the septum on the other side or make space on the other side. Yeah. So that is what you've currently been working on. But interestingly, some of these patients also have HOCM. They have resting and provocable gradients as part of this triad of left ventricular hypertrophy, mitral annular calcification, and obstruction. And so what we're finding is that SESAME could be a therapeutic procedure also just for straight up HOCM. It could change how we think about
instead of sternotomy and
instead of surgical myectomy, and for that matter, instead of alcohol septal ablation, because there are certainly risks to all these procedures. And sure, SESAME is in its infancy and it's in its early stages, but we all know about the risk of pacemaker from alcohol septal ablation, and there are issues with do they have an appropriate septal candidate, right? There's geographic mismatch and things like that.
I don't want to dive deep more into SESAME, but SESAME, do you do this under TE guidance or floor guidance? How do you?
So it's done under both.
Yeah, but how do you measure how much you are taking out?
Right. So our first decisions are made by pre-planning based on a CT scan in terms of location of where we're going to enter, where we're going to exit, and depth. And then intra-procedurally, it's certainly done with fluoroscopy, biplane, mandatory, so that you know where you're headed in two planes, in two orientations, and along with TEE and even transthoracic sometimes to determine depth and location of the wire before we slice.
Awesome. So where are we going next? It looks like every time you think of something you need, it looks like the patient pushing you, right? And the society is to do what you want or to help them.
Right. There are no doubt that this all starts with a clinical need, right? It has to start with a patient, and it starts with one typically who comes to us who has no options, or they've been told they have no options, and they're looking for hope. And what we tell them is, with the tools that we have, we will try our best to come up with a solution for you. And so who knows where we'll be, because it's really who comes next to our doorstep.
Yeah, because as you said, I mean, turning down is becoming less and less from the percutaneous interventions and needs.
So up to this point, we have really focused on either enabling patients to get procedures who otherwise couldn't because of access issues or because of obstruction issues. But with intramyocardial navigation, with Dr. Bruce's intramyocardial navigation, what we really have moved towards, and what we're really excited about, is myocardial restraints. Sort of, if you look at AcuCinch as an example, right? Now there's focal myocardial restraint leading to remote myocardial recruitment and improvements in left ventricular function, or at least bracing the heart, right? Belts and suspenders. And so we actually think we can create a belt around the heart, so to speak, but inside the muscle, so it's not exposed to any bloodstream, and therefore, and also fully circumferentially, so we can prevent further dilation of the heart using some of these techniques as well.
Wow. So the space is still open for innovation.
More to come. Stay tuned.
Stay tuned. Well, thank you so much for all you have done, you and your team. Phenomenal work, and congrats for the lecture. Please watch this videos and others on the SCAI-TV. This is Alraies from Phoenix from SCAI 2023. Thank you so much, Dr. Greenbaum.
Oh, it's my pleasure.
Awesome.